Hello, everyone, and welcome to Elevating Voices for Long-Lasting Change. I'm Vic Armstrong. I'm your host for this conversation, and I am thrilled to be joined today by three very special guests. I'll be joined by our CEO of the American Foundation for Suicide Prevention, Mr. Bob Gebbia, by the CEO of the National Alliance on Mental Illness, Mr. Dan Gillison, and by the CEO of Mental Health America, Ms. Schroeder Striebling. Welcome to you all.
Great. Nice to be with you all.
Good to be with you.
So great to have you all with me today. We're going to dedicate this time to talking about health equity and the importance of health equity in the work that we do. So I'd like to start by asking if each of you would introduce yourselves and your organizations and just share a little bit about why health equity is important in the work that you do. And let's start with Schroeder.
Sure. Well, first of all, I want to say thank you to you, Vic, and to Bob and to AFSP for hosting this conversation and inviting us all into it. It's an important topic, and I'm glad to be here today. Mental Health America is a 115-year-old advocacy organization. We have a national office in Washington, D.C., where we do public policy, research, public education, and state and local advocacy, and 143 affiliates around the country who are direct service organizations providing services in their communities, customized to the needs of their communities, and very often serving those at the margins in their communities. So this is very much a central part of the work that we do. And I want to say also that Mental Health America is proud to be working in close collaboration with AFSP and NAMI and lots of other great mental health organizations. It takes a village, and we're glad to be part of the village with you. At Mental Health America, one of the things that we see, we host a national prevention and screening program where 12 to 20,000 people a day come online to test themselves if they have any concerns about their own mental health, learn more about their mental health. And we see the disparities in mental health show up quite clearly in the data that we get from screening. So not only do we know this from other sources of information and data, but we see this directly in our own data that marginalized and minoritized populations are disproportionately at risk and vulnerable to mental health and behavioral health conditions. So we think it's an imperative for us to put a priority on addressing those who are the most vulnerable, as our affiliates are doing. So that's the focus for us and a little bit about us.
Thank you. Dan, how about you and NAMI?
Well, again, I want to echo my colleagues, my peers' comments. Thank you, Vic, Bob, AFSP, for having these conversations, elevating voices, and bringing us together. And to all the audience members, we hope you get something out of this that you can use in your communities. In terms of who is NAMI, National Alliance on Mental Illness is an organization that started 45 years ago. So we're 45 years young. We started in Madison, Wisconsin, with parents getting around a kitchen table and saying they needed to advocate for their young people that were navigating mental illness. So that's where we started, and we have about 650 affiliates in 49 state organizations, and many of those affiliates are in communities where we say they're the DNA of the communities. They know how to navigate in those communities. 65% of those leaders in those communities are volunteers. So a lot of our workforce is volunteers. What does that mean to this conversation? They've taken their pain and turned it into purpose. And that purpose is their passion. And we do support groups, we do programming, so that when you come in that room and you're navigating something, either as an individual with lived experience or a parent, you see someone sitting across the table that is navigating something similar, and all of a sudden you're not alone. So that's what we're doing. Why this conversation is important and what we're doing is, let's just talk about the rates of suicide deaths among Black men. They've increased over 25% over the last 2 decades. Over the last 2 decades, they've increased by over 25%. Now, suicide attempts by Black adolescents rose by 73% over the last 2 decades. So it's not, whether or not we can do it. It's an imperative that we must do it. And as I've heard you say many times, Vic, We got to meet people where they are. So that's why what Mental Health America does, what NAMI does, what AFSP does, and many of our partners that we work with are doing in the communities is so important. We've got to collaborate. So that's a little bit about NAMI and why we're here and why this work is important.
Thank you so much. Bob, tell us about the work at AFSP.
Yeah, so I'm going to thank Schroeder and Dan for being on this program, and our listeners probably don't realize we probably see each other at least 2 times a month, maybe more, whether we're on the Hill together or talking about priorities together and something called the CO Alliance for Mental Health. So we have a strong relationship, all of us and other colleagues as well. AFSP is very specifically looking at how to reduce suicide in our country. Our mission is to save lives, bring hope to those affected by suicide. And we address the problem, and we're the newest, we're the youngest, which tells you something about how suicide wasn't on the radar for so long. But the reality is we can do a lot to advance the science, to understand better how to do this. And that's pretty recent in our history as a country. Investing in then taking that science and delivering it in programs that are evidence informed, and we measure that, but also advocacy. How do we change policies and legislation that advance suicide prevention in our country? Or the other side of that, how do we come out against policies that hurt that? Equally important. And then the last piece of what we offer is support to those who've lost a loved one to suicide. It's a devastating, isolating experience. We know that it can devastate families, workplaces, schools, communities, So not forgetting that population and those affected by suicide directly. So we work both nationally, like our colleague organizations, and we also have chapters of AFSP now in every state. The District of Columbia and our newest, which I'm so excited, is in Puerto Rico. And so we try to really build on the ground programming as well as what we can do at the national level. This topic, quite honestly, if you go back 5 years ago, not on the radar,
right?
Not being talked about at all in the suicide prevention field. That has taken an important U-turn in recent years. And for a lot of the reasons Dan said, we're seeing just real shifts in the demographics and some populations seeing just really very high increases in suicide. That could be around Black and Brown youth, as was mentioned. It's also LGBTQ youth, but also other populations, whether that's our veteran population, people in rural America. So there's a lot of ways to look at equity, but it all comes down to who's being impacted and not getting the services and the attention to change that and save their lives. And that's why we do it.
Yeah, absolutely. So thank you all so much for sharing in your introductions. And one of the things that I noticed is that you each spoke about community and the importance of community in the work that we do. Growing up in a very rural community in Eastern North Carolina, a very small community, population of about 4,000. Also being the son of a preacher and hearing all my life growing up that suicide was not a Black issue. It was not an issue that impacted the Black community. In fact, I was told very clearly, suicide is a white problem. It's not a Black problem. We know now differently because we see the rates of suicide increasing in Black and Brown communities. But one of the things that has also resonated with me is that not only was there a narrative within my community that was incorrect, but there was nothing coming from outside my community to correct that narrative. There were not organizations that were reaching into my community and saying, no, mental health challenges and suicide is an issue in the Black community. It is an issue in your rural community. And so I guess that raised a question for me of how do we engage communities now, especially communities, historically marginalized communities that we have not had relationship with in the past? How do we engage them now in a meaningful way? And Dan, let's start with you if you don't mind.
It's a great question, and thank you for sharing your orientation and your upbringing. And I grew up in a city in Washington D.C. and my father always told my mom in our presence, "Oh, the boys are fine. They'll shake it off. They'll shake it off." It was never talked about, and I lost my contemporary to suicide in 1986. And we grew up together. So the point in fact is that happened in 1986. It's 2024. We never talked about it, and that ripple effect. What's happening now is so wonderful because we're telling our community, first of all, we're going into the community and we're having the conversations and we're saying, you're showing your strength in your vulnerability. Because one of the things from our community and growing up, Vic, and you know this well, is that you can't show, we were raised to not show vulnerability. We were raised that if you showed any vulnerability, that demonstrated weakness. And it was like, well, what's wrong with that? It was a whole different kind of a narrative that's now changing. And it's very important that we have young people as well as parents know that it's okay. You know, you talk about your diabetes, you talk about some of your other kinds of diseases from the neck down that you're navigating. This is something you can talk about as well. How are you doing from the neck up? So just giving voice to the community and telling the community and being a part of the community and saying it's okay for us to have these discussions. And it's not just okay, it's critically important. And we do that with a lot of different kinds of things. One of those is with a 3-part series called Sharing Hope. And it's a facilitated conversation where we talk about hope and sharing hope. And then what does it look like navigating this that we're talking about today?
Definitely. Thank you. Bob, your thoughts?
Yeah, Dan's comments are spot on from what I could see, and yours as well, Vic, in the sense that I remember 20 years ago in the suicide prevention field, there was an organization that was started by a few lost survivors from the Black community, and they wanted to focus on the topic of suicide prevention among African American and Black populations. We even funded their first very small conference. You know, it was very tiny. The organization failed within a year, 2 years maybe. They couldn't get any traction. And the thing they heard was, this is not a problem. Why are you coming to us? Why are you trying to address this? It's not a problem in our community. And I think that set us back. You know, I think if we had made some traction then, we might not see the rates now, you know, but we have an opportunity now. Can't look backwards, got to look forward. I think the most important thing here is to really approach this with humility and the understanding that we may have expertise, that's fine. But just to think because you have expertise, you're going to walk into a community where you have no history, no traction, there's no relationship, and try to do something is the wrong approach. I'm an old community organizer. I remember way back a long time ago when I started in service development and planning, this idea of you plan with, not for, you know, and I think that's as relevant today as it was a long time ago. But the idea now is to engage the community, understand the community, have them own whatever is developed, because that's the only way it's going to get any real traction. And so I just think the approach matters. Obviously, we have to do something, but we have to do it together.
Absolutely. Thank you. Schroeder.
Well, first of all, I want to second what my colleagues are saying, what all of you are saying. I think you're spot on in all of this. And also, I'll share a little bit personally, as you were doing, Vic and Dan, because I think it's important. We all come from a context, and that informs our perspective. And, you know, as we know, many marginalized and minoritized communities are at greater risk for depression and suicidality, amongst other mental health, behavioral health conditions. My background, I grew up in New York, and I share with you this, Vic, I don't know that we knew this. I'm also the child of a preacher. My father was a Methodist minister who came out of the closet late in life and really went through a lot of depression, went for mental health help, but what he got instead was conversion therapy. And so that, talk about not meeting somebody where they were, and this would have been the 1970s, so not long ago. So not culturally responsive, not personally compassionate, etc. And ultimately, he went on to have a couple of suicide attempts himself. So we know historically the harm, right? We know what it means when we don't meet people where they are and where it can lead, and the dangers. So to Dan's point, the talking about it, the giving voice to it, this is so critically important. And to being able to say that we want to meet everyone where they are, no matter who they are, that everyone's story is important. Everyone's story owns its own dignity. Every person owns their own dignity, and we've got to meet that where they are. When I mentioned our screening program before, and we see the disparities still showing up really greatly, especially amongst youth. Youth are the most frequent visitors to our screening program. So we know that people under 25, 26 are very concerned about their mental health in this country right now. And we consistently see that Black and brown youth and LGBTQ youth are telling us that their rates of suicidal ideation are much higher than other youth. So this is still going on. It is a particular issue, for youth, and figuring out how we meet youth where they are is really important. And especially for those of us who do have some anchor in this history, we got a couple decades perspective here to remember what it was like and to understand the harms that can happen when we aren't meeting people where they are, when we're not giving voice to it, and when we're not figuring out a way to help people understand that they're not alone.
Yeah.
Really critically important.
Schroeder, I want to stay with you for a minute because you mentioned in your comments, you talk a lot about youth and reaching youth, and then you've shared as well about the uptick in suicides, especially particularly among Black youth. A lot of what we deal with in this space is really generational issues. It's as I shared in my lifetime, I've really had to rethink about what mental health and suicide means to my community because I was taught, from a different narrative. So as we're trying to break some of this generational cycle of the way that we view conversation about mental health and suicide, which can make it very difficult to create safe space. How do we break some of the generational challenges that we have? How do we reach the next generation and really get them to think differently about the importance of having these conversations? And I'll open this up to anyone who wants to jump in.
Well, let me just make a comment. I think we have some interesting experience and data now with something called Seize the Awkward, which is a focus on youth more generally. It's a partnership campaign with the Ad Council. It's public awareness, messaging and ads and so on, and on all over social media. In the last 2 years, it's had a very distinct focus on Black and brown youth and LGBTQ youth. And what we're finding in the data, the message is actually resonating better with Black and brown youth than white youth. And the message is about helping a peer. If you know someone is struggling, here's what you need to do to help them. It's peer-to-peer, approach for youth. But the data has been just amazing to see it resonate, and seeing Black and brown youth in particular, and LGBTQ youth as well, saying that they are more likely now, after getting these messages and looking at this information, to help a peer, and that how many have helped a peer. Over 50% of those aware of it have helped a peer in the last 6 months. I mean, we're starting to see this resonate. So it tells me there's real hope that if you can shape the message, and they're hearing from peers in the ads and all the messaging, and it's a trusted messenger in that regard, you can really start to change attitudes and then change behavior, which is obviously what we want to get. So it's just an encouraging thing to see happen now.
Absolutely.
I'll build on that for a little bit and just say that I think you're so right, Bob, about the critical nature of youth. And that's certainly what we hear from our youth leader programs, is that what they want to see is more peer-led programming. And they are really very creative and innovative in the way they are designing community-based, their own youth community-based programming where they are. And so when we ask ourselves, how are we reaching youth to get the message? Sometimes I wonder if it's not that, how are we letting youth reach us to tell us what's important? And one of the things that has really stuck with me recently is a conversation in our Youth Leaders Council where we were looking to learn from them about what works for them in supporting their mental health. And so they mentioned the peer programs that they were developing. They wanted to learn more about policy. They wanted to learn more about fundraising so they could support these programs. But very clearly what they said is that seeking mental well-being for them in community was not about a more medicalized model of mental health where you go to see somebody for a 50-minute appointment in an office somewhere once a week. One youth leader said, mental health to us is about figuring out what makes life worth living. Where do we find purpose? Where do we find meaning? And how can we not be alone in that search? So I think following the lead of youth is really also very, very critical here.
Yeah, and I'll build on what Schroeder and Bob have said in terms of, we say nothing about us without us, and who is the us? And we're talking, and when you talk about young people, they watch what we do versus what we say. And where I'm going with that is that we're pretty methodical, and when I say we, my generation, and I'm 60 plus, we're very methodical, and we've always worked with a certain scope of work and an agenda. Our young people don't work with that same agenda, so we need to meet them where they are and get out of their way, but also make sure they're at the table with us. So what we've done is we first 3 years ago, this is year 4, we put out a call over 30 days for 10 young adults to come work with us to form and frame our work going forward. And we articulated what the scope was, and we had 10 spots. We got 740 applicants for 10 spots, all young adults. Young people care about this. The next part of this is in terms of that we created that cohort. We now have a 4th year of that cohort of 10 young adults. We've got to figure out how to put the other 730 to work. The other part of, we all know when young people come to the workplace, when we came to the workplace, when we were interviewing and someone asked the question, do you have any questions for me? We would ask the standard questions. Young people now, when they come to the workplace and you ask them that question, they want to know about your mental health benefits.
That's right.
The conversation is absolutely changing. And this elevating of voices that you're doing here is so cool, because if we really look at our young people as the amplification of what we want, it can happen. What we've also done is we said, wait a minute, nothing about us without us. So we did a little reflection and said, we believe in lived experience on our board, and we have actually 75% of our board has to be represented with lived experience by our bylaws, but 100% of it. But guess what wasn't on our board? We didn't have any young adults on our board. So we amended our bylaws, and we now have 2 young adults on the board. So they're learning, and they're also advising, and it's helping us, really look at what we should be doing versus what we are doing for young people, and to improve what we're doing with equity.
I had the good fortune earlier this week to sit in the presence of a panel of Black youth who were talking about suicide, and a couple of them had their own experiences with suicidality, and they all at least had some experience with just feeling the pressures of anxiety and depression in their everyday work. But my takeaway from listening to them was that young people want more than just a reason not to die. They want a reason to live.
Yeah.
And I think that, to me, is being reflected more and more in the work that we all do, because I think we understand better now than we did in the past about the need to get upstream, that we're no longer thinking about suicide as something you react to, that suicide is not itself a disease. But I always share with people, it is actually the worst possible outcome of a lot of very complex things that can include mental health challenges, but that also means that we have opportunities to intervene if we have the right resources in the right amount, in the right place where people live, work, play, and worship. And I think that's reflective in the work that we're all doing. But that leads me to another question. Because it is a relatively new conversation, we have been operating in a system because we have not been historically leaning into the equity space. We've actually created a very inequitable system. And so what we're trying to do today is to embed equity into an inequitable system, which means that it takes a lot of intentionality to make sure that that happens. And so I'd like to hear a little bit about how our different organizations are prioritizing health equity in a way that ensures that it's not, like a lot of people are afraid, this is going to be a topical conversation that we'll have today. We won't be having it tomorrow. How do we make sure that this health equity that we're talking about is embedded in our work and that it continues going forward? Dan, you've got a sly smile on your face. I want to start with you.
You know, it's Vic. I probably couldn't play poker with you since you're reading my nonverbals. It's a very powerful question because you're talking about how do we operationalize this differently? If we do what we've always done, we're going to get what we always got. So going upstream, it's creatively, where do we go and how do we go there? And how do we make sure that it's consistent and it's real? So what we're doing is we're reaching out to HBCUs. We're using sororities and fraternities, what we call the Divine Nine. We have a program called the Community Health Equity Alliance. And that is working in communities across the country, looking at, it's almost like years ago, Vic, 12, 14 years ago, we met in the Stepping Up initiative. We saw with that initiative that people were functionally caring about it, but they were working in silos. Well, with the Community Health Equity Alliance, it's going into communities that challenge communities from the standpoint of them knowing what does a continuum of care look like, and making sure that we help them with one, also knowing what are the signs of a mental illness, how to navigate and create their own care journey, and where to go for services, and making sure that there's this construct that they know that there's different elements of that. And we've created a campaign called Crisis Can't Wait. And a part of that is this body of work also. So between the HBCUs, the Divine Nine, and these campaigns that we have that we're doing in over 22 states right now, this is work. And by the way, we want to work in concert with our partners here and everyone else. The other thing is that what I would say is that this is a new day. There was a time where everyone was in their lane and they stayed in their lane. What I love about this, and Bob referenced the CEO Alliance for on mental health. And Schroeder and Bob and many other CEOs are leaders of that. And like Bob said, we meet every couple of weeks. That's new. So we're already examining how do we look going forward. So I mentioned a few things that we're doing. And there's much more, but I don't want to monopolize the conversation.
Thank you. Bob, you want to go next?
Yeah, one really positive indicator that this is not a one and done or the topic of the day. You know, the new national strategy for suicide prevention, which was launched, by the Biden administration, but with a lot of input from all of us and other colleagues and stakeholders across the country and all that, is for the first time reflective of the need to address health equity and suicide prevention. This is the third national strategy. The first two, not a mention. And the last one, I guess, was around 2012. This just came out. There are four major strategic directions. We can talk more about those, but strategic direction 4 is health equity and suicide prevention. And then as that gets spelled out, what does that look like? How do you deliver community-based programs addressed on this? How do you look at research? Another example, and I can tell you specifically for AFSP on that, about 3 years ago, we changed our research priorities to say, we want to understand more about how suicide can be addressed within marginalized and underserved communities. And we want researchers from those communities to study that. And a few years later, this past year, a third of all of our funded research grants, I think we funded about 35 of them, a third of them were addressing the topic of suicide prevention in marginalized and underserved communities. We need to know more about that because it was never studied, and we know culture matters. in community matters in terms of how you can do suicide prevention. So it's just an example, between the new national strategy, it's a 10-year effort. We are all behind that, looking at how we can implement it. And I'm maybe sometimes a skeptic. Plans are great, and you have to have them. But then what do you do with it matters. And that's, I think, where we are as a field and as a collective of public and private sector organizations. How do we make that strategy now really come alive, whether it's in programming, research, public policy, crisis services, across the spectrum, upstream prevention. Mm-hmm. So I think these are things that are going to ensure this is not one and done. This is a fundamental shift and we all need to be vigilant on that. We need to speak out about that and make sure it happens. So.
Absolutely. Thank you. Schroeder.
Well, first of all, I want to say that I love listening to my colleagues and to hear about the work of AFSP and NAMI, and know that it takes all of us to have different approaches and to be working from different perspectives and angles. The research and the national strategy that Bob talked about, all the work that NAMI is doing with the Health Equity Alliance and the Divine Nine and other ways of reaching community, all of which is really important. At Mental Health America, as I mentioned before, a lot of our affiliates are working at the margins already. And I come from a background of community-based work, myself having worked with communities that have really encountered deep damage from intergenerational poverty, intergenerational racism. And one of the most important learnings that I brought with me from that is that the wisdom to address these issues is within the communities themselves. And the leaders necessary to lead these initiatives are within the communities themselves. And that a lot of it is about lifting those up, but they often lack the catalytic resources they need to be able to develop and implement the solutions that they themselves know are necessary in their community. I'll give you just one example. This community that I worked with in Washington, D.C. for many, many years had a reentry program for women who were leaving the criminal justice system and were also experiencing homelessness as they departed. And so the women who were in the housing program where we wanted to invite them developed their own jail in-reach program so that they could go into the jails and tell other women about what the housing was like, what the community was like, what the healing aspects of the community were. And it was all about them. The magic was in the community itself. That's where the change agent was. So that's some of the learning that I bring with me. And what Mental Health America launched 9 months ago was a new initiative called Equity Impact Zones. We share some of the basic tenets with I think what NAMI is doing in the Health Equity Alliance, which is really cool to be able to do this in concert. And what we're doing is soliciting funds as the intermediary at Mental Health America, and then we're distributing them to applicant groups from communities who are communities applying themselves, and we're making the application process as creative, as brief and easy as possible so that anyone can access it. We want to reach folks who may not be accustomed to writing proposals, et cetera, but we want to get to groups who are wanting to close the mental health equity gaps that they see in their communities and where they know they have the solutions and they just lack the resources to implement them. So we'll be the intermediary. We're also going to help them with the metrics, and we have a commitment not to leave them for at least 3 years with those resources, because we know it takes time for people to be able to implement these things. And we also want to encourage innovation and experimentation, and not everything will work, but we want to support communities as they go through that. And we really, again, believe in the wisdom of the communities themselves and the leaders that are already there.
Yeah, thank you so much.
You raise an interesting point in terms of that kind of engagement, which we're learning right now through a program called Let's Save Lives, and it's suicide prevention in the African American and Black community, which, shout out to Vic, really helped to develop. But what we learned is that you can be a trusted source, and the response has been good on that. The exchange of and knowledge changed as a result of it's been good, but they want it to be delivered by people in the community. So the focus is on training people, giving them the wherewithal, and it's a pilot program. It's got a long way to go to get to scale, but the reality is we're seeing a lot of people come forward saying, I want to be trained, I want to present this in my community. So you can play that role of helping without having to do, right? And I think we're learning a lot from that as that's been rolled out. So it's a good example of what you're talking about.
And I think you make an excellent point, Bob, in that communities don't want a savior. They want a partner. They want someone who come alongside them and work with them. And I think for too long, we've treated communities as if we need to come in and rescue and save them. And then we expect their buy-in and their thanks, and then we expect them also to be sustainable when we walk away. Mm-hmm. But I think the difference, at least from my perspective today, is that what we're investing in are things that are already staples in the community. We're investing in things like the faith-based organizations that already exist. We're partnering with organizations like the Divine Nine, the communities are already invested in. And I think that's made a huge difference in the buy-in that we're able to get from communities. We're going to need to wrap this conversation up, as much as I hate to. But I so appreciate having had this conversation with you all today. You are each phenomenal leaders in your own space. And that means you are also phenomenal leaders in this health equity space. And I appreciate the work that you're doing, because I see it. I see it every day. I see the programs. I see the conversations that are taking place. And it does not happen without leaders like you all in place, being intentional about making it happen. So thank you so much for that. And I'm going to get you out of here with this. I'm going to give you each about 30 seconds to wrap up and share anything that you'd like to leave with our audience today. And Bob, let's start with you.
Yeah, the one thing that has not happened yet, but there's really good planning going on, something called Health Equity and Suicide Prevention Initiative. And it's a partnership. It's not AFSPs. We don't want to own it. We want to be a partner and a contributor to it with NAMI and MHA, our federal partners, but also community agencies, community-based agencies, to really sit and look at what is happening and how do we hold up those things that really have promise, and what's not happening that needs to be developed. And so it's going to be a multi-year initiative, but the idea is to kick it off with a big summit in Atlanta in 2025 with lots of partners. Again, this is not something AFSP sees itself, owning. This has to be owned by the community itself, but it's an exciting thing. It's at the front end of it. We'll have a lot more to talk about as that shapes up and as our partners help really to develop it. So just want to leave you with that. And again, I love working with my colleagues, Dan and Schroeder, and so many others in our field.
Thank you. Schroeder.
Well, I want to thank you again for hosting this conversation, and right back at you, Vic, about the leadership that it takes and the example that you set. So we're grateful. I would go back to something that you said, Vic, which reminded me when you said that, preventing suicide isn't just about not wanting to die, it's about finding a reason to live, which reminds me of what we're hearing from those youth who tell us that mental health for them is about finding out what makes life worth living. And as we all have talked about, partnering more largely with communities. So not just in the mental health clinical efforts that we're doing, but where we live, work, play, and worship, as we say. This is, an expansion of our notion of what mental health means, is how we support communities in that well-being. And in that sense of what gives life purpose, what gives life meaning, and whether it's as you were talking about, both Bob and Dan, about the volunteers and turning their, finding purpose and passion in doing that is supportive of our mental health. So I think there's a component of this, which I would venture to even call spiritual, which is an expanded notion of what we mean by mental health and by lived experience. It's about our whole lives.
Mm-hmm. Absolutely.
Yeah, it is. It really is. And, I heard some incredible words, operative words here: trust, partners, hope. We look at the social determinants of health, and there's also the social determinants of mental health. But it all goes back to zip codes. And if we're talking about lifespan and we're talking about whole health, we've got to examine social determinants of health, and we have to look at zip codes, and we have to look at how do we have communities hold on to hope. And to turn that hope into reality, and scaling of programs that work. The other thing is that we've got to look at workforce, and we've got to bring young people into this workforce that look like the communities that they serve. We need to create some equity and balance in that, and there's hope there. And I would say that being at an event last week, I'm looking at it, the social status of Black men and Black boys. There was a congressional hearing last Friday in Harlem, New York, and a mentor drove 20 young men that he and one of his colleagues work with. And these are all 20 young men between 14 and 18 that all want to be medical professionals and mental health professionals. Several of them are going to go to college. One young man is going to Duke in the fall, and he wants to be a psychiatrist. Another wants to go into psychology. You had 20 young men there in white coats listening to the congressional hearing. Where I'm going with that is hope. We've got to make sure that we also talk about hope from the standpoint of it being, contagious, and it can really make a difference. And the last thing I would say is researchers and looking at social workers and all the different disciplines in the space. We need to look at workforce development and making sure that we go upstream. And when you were growing up, that when you sat there, folks would come into your classroom to talk about their careers on career day. Yep. How do we bring some people into talking about career day that do this work? To middle schools and that kind of thing. Last thing I would say goes back to community. We've all said that, and we know that community is really like this. And this is the quote: people don't care how much you know until they know how much you care. So they know if you're authentic. So we got to make sure we do our work with authenticity. And that's a wrap for me, Vic. Thank you.
Thank you so much. Thank you to my guests today, Bob Gebbia with AFSP, Dan Gillison with NAMI, and Schroeder Striebling with Mental Health America. It has been such a pleasure to talk to you. You all give me hope from your leadership and just from your conviction and your commitment to this work. Thank you so much for being with me today. Thank you to the audience for joining us for this installment of Elevating Voices for Long-Lasting Change. And I'll leave you with these final words from James Baldwin. Not everything that is faced can be changed, but nothing can be changed until it is faced. Thank you so much. It's been my pleasure to be your host.
Thank you.
Thank you.